Welcome back to Chapter 11, Inflammation. This is going to be Part B. We're going to begin with this slide. These are factors that can determine the outcome of inflammation. And what I want to begin by talking about resolution, which is what everybody wants, is resolution. And that's going to be the healing of the tissue where there's no permanent destruction. So they give an example of a person getting better after the common cold. Now, fibrosis formation is something that you do not want to have happen. It's scarring, and that is going to occur when there is significant tissue damage, where wound healing just is not going to be enough. Here, when you have epithelial cells that are replaced by fibroblasts, the problem is that it forms scar tissue. And scar tissue is non-functional tissue. So when they give the example of a heart attack, a myocardial infarction, it means that those cells that were cardiac cells are dead, and then it gets replaced by scar tissue, which is non-functional. So a person might have had a heart attack where they lost half of their left ventricular function. That means then that those cells were replaced by scar tissue. It's non-functional. That person has permanent loss of that function, and so they might be down 25% of cardiac function. That's going to be permanent. Abscess formation can occur with bacterial infections, and it's almost always associated with pus. And pus is the cells that have died as well as the bacteria that have died. And then that's going to segue us into chronic inflammation. And in chronic inflammation, that may be what happens if the acute inflammatory response is not resolved. And this is a diagram of this. So here we have acute inflammation. This is what you want, resolution, because then after wound healing, everything is back to normal. You can have abscess formation, and that can end up leading to fibrosis formation. And acute inflammation can also lead to chronic inflammation. And in all cases, you don't want to have fibrosis formation because of the scar tissue, because you've lost function. And it's very difficult in a lot of cases to get that function back. Even when you have other types of cells, tissues, organ systems trying to, help in that recovery period. It's so much better if you don't have scar tissue or fibrosis formation. Now, chronic inflammation. So what it is defined as is, let's say, inflammation that lasts more than 2 weeks. Very often it's months, years, a lifetime. So it depends on the cause. So with the cause, you can have unresolved or repeated acute infections. I'm going to give an example of kidney stones. So in the kidney stones, you have an acute inflammation, and then the stone is able to be removed and you're fine. Very often, especially if there's a genetic component, individuals might end up having more frequent stone formation, and so it then becomes a chronic event rather than a one-time acute event. The other has to do with autoimmune diseases. So autoimmune diseases are when the immune system starts to attack self. It starts to attack normal tissues, normal components of the body, normal organs of the body, normal cells of the body, as if they are foreign or different. It's an appropriate immune response, and because we in most cases don't know how to correct that, we don't really know how to re-regulate the immune system so that it no longer is attacking self, That's what makes it chronic. We are good at intervention when you have acute episodes. We're not very good at figuring out how to stop it at its source. So when a person has a autoimmune disease like rheumatoid arthritis, then that is going to be a lifetime event, and that's the reason for it being chronic. It could start out as an acute episode, and then once blood tests are made and diagnosis is made, if it is an autoimmune disease and you can't re-regulate the immune system, then that person has a chronic infection and a chronic inflammation. So here we have rheumatoid arthritis as an example, multiple sclerosis is another example. And when we get to those chapters, we will get into more detail. And this just goes into another type of autoimmune disease where you have an unregulated or incorrectly regulated response to a microbe, as you can see in inflammatory bowel disease, or an unregulated response to a trigger like pollen, and that can trigger asthma. You can also have chronic inflammation if you're in an environment where the trigger is present, let's say, continuously. So it could be a irritant that is outside or inside the body. So they're going to use an example of outside. The exposure of silica, which could be an environmental type of thing, job-related, where a person is exposed unbeknownst to them for a long period of time, which is going to set up a chronic inflammatory response. In this case, chronic inflammation of the airways of the lung. So we have cell types, and there are different cell types for chronic versus acute. And remember, with acute, it was neutrophils, and it was mast cells releasing histamine, and neutrophils would do phagocytosis. And with chronic, on the other hand, what you have are macrophages and lymphocytes versus the neutrophils in acute. So chronic inflammation is associated with tissue destruction and replacement of damaged tissue with fibrous scar tissue. And the occurrence via angiogenesis is something we'll get into later. All right, so this is a fantastic table that is getting into the role of these inflammatory cells that are involved in chronic inflammation. And it's worth going over. So let's start with macrophages. We know that they are in the tissues, macrophages, in the blood, monocytes. We know that they're phagocytic. We know that we don't have as many of them as neutrophils, but that they are extremely effective, not only at phagocytosis, but segueing into the lymphocyte response. So we have the active in phagocytosis. It also can release certain, remember, cytokines. Cytokines are merely signal molecules that are made by certain cells of the immune system. And sometimes the cytokines are going to be stimulatory, some are going to be inhibitory, but macrophages absolutely can make a repertoire of cytokines. And normally it should initiate tissue repair, but in pathological situations, it can contribute to scar formation. Next on the hip parade are lymphocytes. So we know that there are the B lymphocytes, the T lymphocytes, we have subsets, and they are very much involved in the playing out of chronic inflammation. So the lymphocytes can contribute to autoimmune diseases, hypersensitivity diseases, and again, they can also secrete cytokines, some inhibitory, some excitatory, and some of the cytokines in pathology will promote inflammation. Eosinophils, these are the first time I've talked about them in this chapter. And eosinophils and basophils are granulocytes. And in a person that's healthy, the percentage of eosinophils and basophils is less than 1%. It's very, very low. What eosinophils and basophils are all about is balancing off each other. So eosinophils are able to make antihistamines, basophils are able to make histamines, and they are very active in individuals, especially in situations where oral fecal hygiene is not the greatest, and they are wonderful at eliminating parasites, gastrointestinal parasites. They also, however, play a role in the pathology of hypersensitivity reactions. So when you have a hypersensitivity reaction, again, it's the immune response that is aberrant, that is inappropriate, and eosinophils can contain toxic granules. And it's great if it's attacking a parasite that's in your intestine. It's not so great if it is inappropriately getting involved with a hypersensitivity reaction and destroying surrounding tissue. Next on the hit parade, mast cells. Now, mast cells are called mast cells when they're in tissues. They are called basophils when they are in the blood. They will be able to store histamine and release it when the trigger is there. And mast cells, because of histamine and other cytokines that they also have, such as prostaglandins and so forth and so on. So they are involved in chronic and acute inflammation. They are primarily involved in hypersensitivity reactions, especially allergies and anaphylaxis, and they secrete cytokines that promote inflammation. And then, last but not least, neutrophils. Now, they are a major player in acute inflammation, but they can be a minor player in chronic inflammation. And next slide. Okay, so here we go. So what are some of the systemic manifestations of inflammation? Fever is something that we haven't talked about yet. Fever is not going to be evoked in all cases of acute or chronic inflammation, but in some cases, probably through the high school of evolution, there are some pathogens that are very difficult to kill and eliminate. And fever is a fantastic way to add to your repertoire of bactericidal agents, virucidal agents that can help you resolve that. So I'm going to use as an example influenza virus. When you get the flu, one of the reasons or one of the ways you can tell the difference between the flu versus a common cold, then it's because the influenza virus will evoke fever. And the endogenous and exogenous pyrogens. Pyrogens are a very fancy term for those chemicals that will evoke fever. And you're going to have the pathogen itself be the trigger for the fever. So that's the reason why they're called exogenous pyrogens, because the influenza virus, or it could be bacteria such as staph or streptococcus, and what they then do when they infect the body is they are going to be releasing chemicals that will trigger immune cells to release endogenous pyrogens. The thing about this is you are going to start a cascade. It's a fever cascade, and what will culminate in that cascade will be the production of prostaglandins. And prostaglandins are important in fever because they can directly go to that area of the brain that controls body temperature. And that area of the brain that controls body temperature is the hypothalamus. And so the prostaglandins at the end of this fever cascade would then upregulate the hypothalamus so that the quote-unquote new normal is going to be 101 or 103, etc. The thing about that, which is fantastic, is as long as it doesn't get dangerously high, your body cells are fine with 103. Microbes are not. And so it gives you an additional weapon in your armament towards fighting these types of infection. The other thing that can manifest is serum proteins. Now, serum proteins that are involved in acute and chronic inflammation are usually made by the liver, and they can release a number of cytokines. CPR is important. It's C-reactive protein. And C-reactive protein is an indicator of inflammation. So if you have a patient and you take a blood test and you see that their C-reactive protein is quite high, you may not observe when you do a physical where the inflammation is, but if the C-reactive protein is quite high in a blood test, then you know that you will have to do further tests. It may not be evident, but in the body there is definitely inflammation going on. Leukocytosis. Because white blood cells are involved in the fighting of acute and chronic inflammation, then they are going to be elevated during an inflammatory reaction. And that is referred to as leukocytosis. So in leukocytosis, it's an elevated white blood cell. Do not memorize the numbers, but just to know that when there is acute or chronic inflammation, then it's very common to have an elevated white blood cell count, and that is referred to as leukocytosis. And the last bullet at the bottom right here is it says if it's an increased neutrophils, it's acute inflammation, increased monocytes, chronic inflammation, increased eosinophils, allergic reaction. So this is fantastic for reference. And the only thing that I want you to know are the terms, meaning that neutrophils are there normally. If you have a very high count of neutrophils, that's called neutrophilia. And if you have a very low count, that is called neutropenia. We'll get into the specifics when we get into further chapters. Lymphocytes. If you have a high count of lymphocytes, that's lymphocytosis. If you have a low count, that is lymphopenia or lymphocytopenia. Again, we'll go into more details when we get into specific chapters later on in the semester. Monocytes. If you have a high count, monocytosis. If you have a low count, monocytopenia. Eosinophils. A high count, eosinophilia. And if you have a low count, eosinopenia. And last but not least, basophils. If you have a high count, basophilia, and if you have a low count, basopenia. So what are some disorders that are associated with chronic inflammation? These three are, I suppose, chosen because they all begin with A. I'm not exactly sure. But Alzheimer's is a chronic inflammatory disease causing dementia, loss of memory. There are two types of proteins that are involved. I am not holding responsible for that right now because when we get into the nervous system, we'll get into the whole issue around beta amyloid and neurofibrillary tangles. Asthma is another chronic inflammation. It can be managed. You can help the person to avoid triggers, but it is one of those diseases that the person tends to be asthmatic for a long period of time, perhaps life. And So we know that it obviously is a airway inflammation, and it's going to be involved with IgE and bronchoconstriction and things of that nature. Again, when we get to the respiratory tract, we'll get into more detail about asthma. And when we get to the cardiovascular, we'll get more into atherosclerosis. But the formation of an atherosclerotic plaque, especially in coronary arteries, is a chronic condition. And over years, decades, and eventually the plaque can build up to start to occlude blood flow. And then that is obviously problematic. And in all of these cases, so Alzheimer's is a nervous system chronic inflammation, asthma is respiratory chronic inflammation, and atherosclerosis is a cardiovascular chronic inflammation. And that's it. So that is going to be the end of chapter 11. So thank you, and I will talk to you soon.